Hi, everyone. My name is Casey Lewis. I am a speech language pathologist, a certified neonatal therapist, a certified lactation counselor, and I'm also certified in neonatal touch and massage. I am here to present this webinar, Achieving the Goal, an integrated multidisciplinary NICU or NICU where everyone has a voice. I'm so glad you're here today. My disclosures are that I am the owner of TechScope LLC. TechScope provides mobile endoscopy or mobile fee services to the Dallas-Fort Worth Metroplex. I'm also employed by HCA Healthcare, where I do receive a salary and I work in the NICU. And lastly, I receive an honorarium from Dr. Brown's Medical for creating this webinar. Before I get going, I also wanted to directly thank Dr. Brown's for having me today. It means the world to me. Some of you may know this is kind of a dream for me. I can't believe I'm here in this position in my career. To have the support from Dr. Brown's means so much. And again, thank you for coming. So this is our time-ordered agenda. From 12 to 12:05, I'll be doing my introduction. I'll explain a little bit more about myself. To 12:05 to 12:15, I'll be discussing the NICU team members' roles and responsibilities. 12:15 to 12:30, I'll be discussing how to overcome potential barriers to multidisciplinary collaboration within the NICU. From 12:30 to 12:50, I'll be offering a discussion of NICU feeding programs and the importance of continuity of care. And 12:50 to 1 o'clock, I'll also be addressing questions. Before I advance, a little bit about me. I started my career in the skilled nursing facilities. I later went on to do home health after work in the skilled nursing facilities. I did a year in the public school system. I then landed a job doing 50% of my time in the adult ICU and adult acute care, as well as 50% of my time within the NICU. I later advocated for a full-time role in the NICU, simply because I just don't believe that a NICU can be as successful as it should be without full-time therapy coverage. So my passion is the fragile infant as well as dysphagia across the lifespan. The objectives for today are that we will list at least 2 ways to foster collaboration among disciplines, list 2 factors in making decisions on nipple selection, and name at least 1 way the new ICD-10 codes for pediatric feeding disorder can affect continuity of care. So before I get going, I want you to turn off all distractions, make this time count. We don't have much time together today, but it can be as meaningful as you want it to be. So if you could put your phone aside, put it on silent, maybe you pause this webinar and start a time in a different time when you feel like you can be really focused. I want you to be all in with me so we can get as much benefit as possible. So let's get going. In this webinar, I'm going to show you that creating a strong, multidisciplinary, and well-integrated NICU team is possible. By the end of our time together, you're going to learn steps you can take to help make this into a reality. So I adore Brené Brown. I think I've listened to all of her books on Audible. I'm in the car so much for my business, so I'm always listening to books or podcasts. And I almost feel like she's like a mentor to me in some ways. So if you feel inclined to research her books, I encourage you to do so. It's been very helpful for me personally in navigating my career in the NICU, my career as owning a business, as well as just in a personal way, being a friend and a wife, and even a mentor to others. I love this quote. She says that courage is contagious. To scale daring leadership and build courage in teams and organizations, we have to cultivate a culture in which brave work, tough conversations, and whole hearts are the expectation, and armor is not necessary or rewarded. I fall back on this idea of armor a lot now recently, I feel like since this, her literature, her writings have meant so much to me. It's really kind of like taking down our armor and figuring out how to foster true connections with our peers within the professional settings we navigate, specifically the NICU. If you work in the NICU, you likely know that it is often an intense environment filled with highly competent individuals, as well as many different personalities and egos. And I mean that in the most positive and professional way possible. In my world, this is the truth. And everything I say in this presentation is my personal belief and my thoughts. So I want you to take what I say, knowing that this is what I believe in, how I would teach you if you were face-to-face with me as well. In order to truly succeed within the team, you must learn how to navigate what can often be uncomfortable situations and experiences. I mean, in the NICU, it is a critical care unit. And I think it's easy to lose sight of that once you're in it for some time. I think at the beginning, for me personally, everything was so new, and I was in, I don't know if I was in shock, but I was awed by so much. I just felt like, wow, I want to be a sponge and I want to learn everything I can. And then, as we know, if you served in the NICU or in any healthcare setting during the COVID pandemic, it's really easy to become habituated to things and almost even numb ourselves to certain emotions and experiences based on what I would call past traumas working within the NICU. So I think it's important to address whatever that could be for you and know that that is expected in this environment. What you will be navigating some situations that are going to be difficult if you haven't already. And at the end of the day, you have to remember that you're navigating human beings, and it's important to figure out how to foster that strong connection. There's also a quote out there that I like to reflect on, but I also believe in this as well. It's in the past, jobs were about muscles. Now they are about brains. In the future, they will be about heart. And I really think specifically during the COVID pandemic that it was a lot about what we knew and a lot about the brains per se. But we also know that navigating COVID specifically, we didn't know a lot, and we had to lean on each other to figure out how we're going to handle things, how we're going to navigate certain situations. It can go as much like if you had to figure out how we were going to navigate skin to skin with a mother who presented with COVID. So those are some things that I'm talking about. So as a speech language pathologist, which I am, with specialties in caring for the fragile infant within the NICU, I want you to know that I'm in this with you. I know this presentation is not specifically just for speech language pathologists. There are many different professionals who could be viewing this webinar. So I want you to know that I'm in this with you. We are equals. And I hope that you can take something from this presentation and take it to your NICU. So working in the NICU is truly one of the most complex environments in healthcare. And this is something I don't think I was prepared for personally. So you may feel unheard. You may feel a sense of, where do I go from here? You may feel overwhelmed. And by the way, those are things that I felt. And sometimes I still feel. So although you may not experience these exact feelings, I want you to know that whatever you may feel, your feelings are valid. I also want you to know that it is possible to create a healthy working environment within your NICU where everyone has a voice. This is difficult to do, and I'm not saying this is easy. You have to have support from your leadership. You have to have support from your charge nurses. You have to have support from your providers within your therapy team. Everyone has to be on the same page and willing to put in the work and get vulnerable with each other. And I'm telling you now, it's hard to do, and I recognize that, but it is possible. We must model kindness, clarity, and hope. And when I say these things, I don't mean them superficially. I mean them honestly, and I mean them in a way that I want you to try to get vulnerable within your NICU and within the colleagues that you navigate. We must not use power over people to achieve our end goal. So power is the ability to achieve purpose and affect change, but what could make power negative is how it's used, if it's used in a negative way. And so that's something to keep in mind, because this has the possibility of creating a toxic work environment. We must find a way to cultivate commitment and shared purpose and learn to put our egos aside. This can be challenging, and all of us have egos. I have an ego, and I know that, and I recognize that, but it's something that I personally had to put work in and continue to put work in to be a better professional and a better human being in general. But as you can imagine, if you're not currently in the NICU, there's beeping going on all the time. There could be nursing running to a delivery where a 24-weeker is being born. It can be chaotic. And so it's hard in those moments to figure out how to navigate everything. That's why you have to figure out how to navigate a shared purpose and form authentic relationships within your team to best navigate those kind of chaotic situations. My husband is a combat veteran, so I listen to a lot of his books on Audible when I'm driving in the car, and I really like Jocko Willink's work. He says that when personal agendas become more important than the team and the overarching mission success, performance suffers and failure ensues. And I can speak to this personally within my experiences within the NICU. Some people have different agendas, and if we're not all on the same page, sincerely, we're not going to be as successful for the babies that we're meant to be there to serve and help, and their families. So before I get going much further, I kind of want to give a linear timeline about where we're going, because this is kind of how my brain works. So first, again, we'll be discussing the NICU team members' roles and responsibilities, suggestions for how to overcome potential barriers for team collaboration, discussion of NICU feeding programs, importance of continuity of care, discussion of pediatric feeding disorder, and then the references for this presentation, as well as a Q&A. So the first pillar is discussion of the NICU team members' roles and responsibilities. And I want you to know that each team member is valuable. Just because I'm a speech language pathologist doesn't mean that I just focus on feeding. That is a primary role of myself, but I also can offer value in other ways, like offering two-person cares, because I am what I call a neuroprotector. And on the same page, a bedside nurse isn't just focusing on the care of the infant in that time frame, just the general nature. The speech language pathologist, occupational therapist, whoever also is the feeding specialist in the NICU, I hope is following up on the expertise of that bedside RN to get insight about how that baby has done over the past 12 hours if it's end of shift. So I want you to know that I believe this. We all are valuable. So this list is certainly not all encompassing, and I want you to know that. And this is just some general definitions for you. However, the neonatologist is a physician who specializes in the diagnosis and treatment of preterm and/or sick-term infants and directs the medical care of infants requiring hospitalization within the NICU. The neonatal nurse practitioner is a registered nurse who has completed advanced education and training in the care and treatment of newborns and their families, examines, diagnoses, and designs a care plan for the infant, and serves as an education resource for the NICU team. The neonatal therapist is an occupational therapist, physical therapist, or speech language pathologist who provides direct care and/or consultative services for the preterm and or medically complex infant in a neonatal intensive care unit, focusing on neuroprotective care with developmental outcomes held paramount. The registered nurse manages the neonatal care plan. They collaborate with the infant's providers and are with the infant for 12 plus hours a day. The respiratory therapists, they help babies breathe. Often when their lungs have not fully developed, they care for infants with upper respiratory infections and lung-related conditions. They are likely to attend all high-risk deliveries. The dietitian, we know that good nutrition is an essential component of the infant's health, particularly those facing medical challenges. Dietitians may work daily with the medical team to optimize the infant's nutrition. The social worker helps the family navigate personal or family-related challenges and helps to coordinate services outside of the hospital before or after the infant goes home. They help with insurance or financial problems, parenting, family conflicts, and finding community resources. The chaplain, generally they're spiritual caregivers who support the infant's family with decision-making or healing. The volunteers, I hope your unit has volunteers, they help to support the NICU in whatever capacity that is determined by each specific unit. They may greet the family members, they may help with storage of supplies or offer encouragement to staff. Again, this list is not all encompassing. The point is to show you that there are multiple team members involved in the infant's care, which means a lot of expertise within the walls of the NICU. The second pillar is suggestions for how to overcome potential barriers for team collaboration. Leaders must own everything in their world. I found this picture and I really like it because I feel like this person probably just saw something traumatic or maybe, and they're just trying to digest what just happened. Or they had a conversation with a colleague that maybe didn't go so well. They're trying to navigate what happened. At least that's how the picture makes me feel. I like to say, no matter the corporate hierarchy that you might work in, you are a leader. And it's important for you to own what's in your world. You have the ability to change things. I don't want you to feel like, well, my boss said this, and maybe you don't feel like you have the ability to facilitate conversation or to do something that you feel is best. But I want to encourage you to get into those conversations. Your voice matters. And it's important that you share that with your team. So my best advice is really to get to know your teammates. And I really mean to get to know them genuinely and authentically. Like, I don't want you to feel like you're just getting to know them to get to know them because I'm telling you to. Like, to really try to get to know them as human beings. What are the names of their children? What is their favorite drink? I say this because sometimes I would surprise some colleagues with maybe a gift card to Starbucks, or I would bring them a soda if they like the soda. And it helped them know that I was thinking about them. Or where do they like to travel? I like this picture because it's really like you're connecting, and I know it might sound silly, but you have to do that. And I also think it's important to know that this is not going to come quickly. Some of the relationships I have with some of my colleagues, maybe we just got to a point where we could understand each other. And it takes a lot of work, but it can't just be one-sided. Both of you have to try to come together and get to know each other. Brene Brown, she also says that it turns out that trust is in fact earned in the smallest of moments. It is earned not through heroic deeds or even highly visible actions, but through paying attention, listening, and gestures of genuine care and connection. So some ideas are to attend multidisciplinary rounds. And actually, when you attend them, speak up. I had to fight so hard, historically speaking, to have a place during rounds. It used to just be to the providers and the bedside nurse, and there was no therapy. So I fought hard to get a role in rounds. And then you have to also figure out, when is it your time to speak? And I think that it's important for the providers to know, like, you're not just there because on paper you're supposed to be there now. You're there because you're there to offer insight, and it's important to utilize that time with them, because that's also how you're getting to know your providers. And that's also the time when you get to advocate for your patient and their families with the whole team. I hope the whole team is there. If not, that's something else to advocate for. Communicate the why to your team members while at the bedside. Teach in the moment. This is something I had to learn, and I think also get comfortable with. I think, and historically speaking, when I was a younger clinician, I might have felt that I was teaching in the moment, and maybe I was, but I certainly wasn't to the extent I do now. This is hard to do, and I'm just speaking for myself. You have to get comfortable with speaking what you know to your colleagues in this critical care unit, where it's can be chaotic and a lot going on. So that's why I personally have done a lot of work myself to get comfortable with being confident, speak in, you have to know all these things. First of all, that takes a lot of work. And then you have to build the ability to have confidence to speak up. But it's important, because that's when your colleagues actually can hear why you are saying what you're saying. Because I think before I started in this NICU I serve, I would offer a recommendation, and maybe the staff didn't feel like they really understood why. I'll get to that shortly. I also want you to talk to your providers, not just during rounds. If they're charting or they're sitting at their desk, go up to them. Don't say, what's your favorite drink? Like with maybe your bedside nurses or your therapy team. Because typically in the NICU I serve, the providers don't have a lot of time, specifically the physicians, because in my unit, they rotate to different facilities within the Dallas-Fort Worth Metroplex. So they're only there for a short time. But if I want to elaborate more on something I said during rounds, or get a thought like, why are you recommending this? And I mean that in a professional manner, like that's the time to ask them, because that's showing them that you want to learn and you want to do better. Because they need to know that you're really in this with them. Like, they need to know that you are really trying to also put into action what they're recommending. The world of feeding is very complex. And I know throughout the world, there are different practices regarding maybe feeding on different high flow nasal cannula amounts, or feeding with the various nipples. But this is where change happens, is when you have these conversations. Otherwise, it just might feel like you're just following a protocol rather than also speaking to why you're doing something. And lastly, you want to ask your teammates if they know how to access your notes. Because again, I might write a recommendation on the bedside board, and there's been a shift change, and maybe I'm not there for a day. The staff needs to know how to read my notes, because that's how I can, I guess, teach in the moment per se when I'm not there. If you're a speech pathologist or occupational therapist or whoever the feeding specialist is, the team needs to know why you're recommending what you're recommending. So if you're not documenting on the board, start doing that if you have a board, and then also write a good note and show your team how to get to that. Because historically speaking, in the NICU I serve, a lot of team members didn't know how to read my notes. And if they had, I think that would have fixed a lot of conflict per se. So does your unit use a staffing board? If not, advocate for one. This allows everyone to know who is on staff that day and sets the team up for success. So this is an example of the staffing board that is utilized in the NICU that I serve. It says who the neo is, who the neonatal nurse practitioner is, who the charge nurse is, who the speech pathologist is, who the physical therapist is, and who the RT is, respiratory therapist is, RT, for that day. My unit specifically does not have occupational therapy, but we have 2 STs and 1 PT. And you can see on that, that week, every week we'll, or before the week, we will put what days we're going to be there. That week I was there Monday, Wednesday, Friday. And you can also see on the PT section, it says when she's going to be off. So the staff knows to not expect them. Rather, it's not just like, where's Casey? Why is she not here? It can really prevent communication breakdown and offer some predictability to the team members, so they know what to expect. I know this might sound silly, but really it has helped mitigate a lot of conflict and also set the infant up for success in following the care plan. Because if I'm going to be out a certain day, I'll say the other speech pathologist's name is Chloe. So I'll say, follow up with Chloe on this day. Because this also goes back to following specifically the nipple that is suggested by the feeding specialist, because we need that consistency of care. And so this is a way to help provide consistent care. You can also see that the census will put the number there. I erased that just for privacy purposes, but you would put the census number there too, just to kind of get an idea of who is there. And actually below that, it has all of the nurses' names and what number of the bedside they have that day. So it helps me when I walk in, okay, say Caroline has these 3 numbers. I know to just go talk to her. Hey, I wanted to follow up with this baby. What are your thoughts today? What are you seeing? Another thing to advocate for is team phones within the unit. This is obviously more costly if you already don't have this, but it's a way to, again, prevent communication breakdown. If you don't have this, if you're comfortable with sharing your personal number with your team or the charge nurse, this may be an alternative option. Sometimes I will step off the unit to go to the mom baby floor, because I do serve that floor too, with the goal of preventing the need to go to the NICU for any feeding problems. Or maybe I'm going to take a lunch early, and maybe I'm so hungry that day, I'm just going to step off the unit. And I want the team to know that they can easily contact me, maybe for a first feeding, or maybe for 2-person cares. I need to have that open line of communication with the team, and they know they can call me. The charge nurse also sends out a broadcast to the whole multidisciplinary team within the NICU to say, hey, we're rounding at 11 a.m. Please be here. Or it just lets everyone know to be on the same page, and offers a way to, again, prevent communication breakdown. So how do you communicate your feeding evaluation recommendations if you are the feeding specialist in the NICU? Again, are you just writing on the board? Are you writing on a clipboard? Are you writing on your notes? I have found that just writing a note, it's not the best way to navigate this. You have to, this is in my world. I have to write a note. I have to update the board. And this is the last edition that we have done, with thanks to a nurse in the NICU I serve. It's a shortcut, I guess, to have staff know when the last eval date was. The unit I serve has coverage sometimes 5 to 7 days a week, sometimes 5 to 6. We do cover at least one weekend day. So it would be about 6 days a week, just depends on what's going on, but we will update that every day. And even if we didn't feed the baby, sometimes we'll change the date on there to put the current date, because maybe we had a conversation with the bedside RN or the bedside, or the charge nurse or the provider, just to check in. So it lets everyone know that we're checking in. This is not like a week old recommendation. This is current. You can see the different nipples that my NICU utilizes. We have the Dr. Brown's ultra preemie, newborn, transitional nipple now. We still have written newborn on this, but it is not called that anymore. And the level 1 nipple. And then we also have disposable nipples. So we use Similac or Impamil. So you can see the slow, it says gold or green, the standard clear, other or pacifier dips by the SLP only. And other is where I'll write breastfeeding or nuzzling or dry breastfeeding. there's not a lot of room, but I'll put like BF for breastfeeding. And there's a little magnet on the back and it goes on the whiteboard. So my recommendation might be a little written on the board, but if this is just an addition, I know it might seem like a lot, but it really helps us all stay on the same page. So thank you to that nurse who made this. So how does your team communicate updates to parents? This is the bedside board that I'm speaking of. I blocked out the name of the hospital just for privacy purposes. That's why my hand's there. But you can see it says what the date is, who the parents are, the caregivers, and we can put their phone number on that. The nurse, the charge nurse, who the provider is for that day or providers, the therapist for that day, when they last had their bath. What are we doing for oral care? Like if hopefully mom is bringing in breast milk or colostrum if she was just delivered, the age of the baby, the day of life of the baby, what they're eating, is it 24 cal, 26 cal, what formula with what breast milk, when the last time skin to skin was done, and the last time they had an event, and so on. And then we also have the white magnet and the pink magnet. The white typically is more for the nursing staff specifically, just to give them a check off the box and when they did something. And then the pink is that magnet that I had just described. So not only is it able to promote better understanding within the whole team, but the parents can come in and see what the updates are for that day. Also with the bath, generally in my NICU, that's driven by therapy because we do the best we can to really, it's kind of, we're trying to help the nursing team as well. And so that's an ownership that we have taken on. So we will schedule that with the parents. So I always kind of say it's kind of like a hair appointment. We'll schedule and say, can you come on Tuesday? What time works best for you? So again, that's another thing with the bath. Does your team utilize a formal rounding document? My NICU does, but they also found that some nurses kind of already have their system. But if they don't have their system, we also have a formal document that the nursing staff can utilize when they're presenting on their infant. So in my NICU, the bedside nurse presents on the baby to the providers. And then the feeding specialist, speech pathologist, OT, PT speaks up and adds input. Maybe it's not just about feeding. Maybe it's when we are going to navigate skin to skin, because with some infants, it's appropriate to have RT, nursing, therapy, all there because of safety concerns for that specific situation. Maybe the PT is speaking about something they found in terms of mobility that's outside of my scope of practice. I'm a speech pathologist, but that's when we pop in. So again, my unit does utilize a formal document if the bedside nurse doesn't already kind of have her own system. The formal document has such things on it, like when was the UAC inserted, what the code status is, some things about pharmacy, things about case management, things about lactation. So it kind of covers everything. So that's also a suggestion if you are figuring out how can you better navigate rounds, because it makes things more efficient as well, but it also kind of checks off all the safety boxes as well. So pillar 3 is discussion of NICU feeding programs. I believe that establishing a system is absolutely necessary. I like this picture of this girl holding up the map because that's kind of how I felt when I first started. I was walking into a NICU that didn't really have a system. I think they might have thought they had a system, and I mean that professionally and respectfully, but there really wasn't a system. So I was looking, to figure out how can I navigate this best, and how can I create a system for the NICU if in my situation. So do you have standing orders on all infants admitted into the NICU? Do you receive orders at a certain age? Does your NICU request you on consult only? I believe that preventative care is best care. So I don't think the consultative model of care for therapy services is really the most up-to-date practice. In the NICU I serve, we have standing orders on all babies admitted to the NICU, because remember, as the SLP, I don't just focus on feeding. And then what is your role once you receive orders? Like if you've got to define your role within your team. Are you fully integrated into the NICU team? I mean, are they texting you to say, hey, mom's here for the first feeding, can you come? Or, hey, we're going to do skin to skin at 11, can you come? Help with that transfer, help educate mom. Do you offer recommendations and then leave? Please don't do this. If you're doing this now, figure out a way to be a little bit more integrated, because you're more likely to have your care plan followed. What is the system for following the caregiver's feeding plan? Does your unit offer a protected window to focus on breastfeeding? And I've also found that some units, I think they believe they might offer a protected window, but really when you're getting into those individual conversations with the bedside nurses or the therapist, you might find that there really wasn't a protected window. So if there's not, this is a great idea for a project for your unit to facilitate this, because it is important that we're following the parent's care plan. If they don't plan to breastfeed, you can educate them on the benefits, but go on to bottle feeding. They are the team captain in the baby's care. Does your unit actively encourage skin to skin care? Again, sometimes I have found that, like, I'm a believer that if the baby's in the isolette, we need to be encouraging only holding skin to skin. And sometimes I found that sometimes the staff might allow a parent to hold swaddled. And this isn't best care. If we need to be educating the caregivers on the benefits of skin to skin care, what to expect, how this protects their baby, because this is our role in that age and the nature of the critical care that the baby's in at that point in time. So some units follow an algorithm, incorporate the infant-driven feeding program, or follow a specific protocol. In whatever way your NICU chooses to operate, you need to make sure the process is well understood, well adapted, and well respected within the entire team. So some suggestions for improving collaboration include meeting with providers, presentations to providers, forming a committee with bedside nurses to dive deeper into unit-wide problem solving, discussions with NICU nursing leadership, and so on. These are some things that I have done. I have given multiple presentations to providers over the years on certain topics. And I have a wonderful relationship with the regional physician that leads the NICUs in my region. And I can't express to you how thankful I am for this relationship, because it has allowed me to have a greater impact. And so again, that's just an idea for you. It goes back to the fact that we really have to have these good conversations and good relationships with our providers and put in the work to create that, because it can facilitate much more significant impact. So in terms of bottle nipple selection, there are two options. One is disposable, two is reusable. Nipple selection is not based on a gestational age, but rather the infant's comorbidities as well as feeding abilities. When selecting a nipple, we need to consider the infant's weight, birth age, respiratory history, current respiratory health, as well as autonomic stability. And again, please know that this list is not all encompassing, but it's really just suggested to promote a general understanding. Does the infant have a history of intubation? Is the infant currently requiring high flow nasal cannula? Can the infant maintain his or her own temperature? Does the infant have a history of frequent events like apneas, bradycardias, or DSATs? I really like this picture of the butterfly, the blue butterfly amongst all the orange, because it just provides the idea and importance of individualized care. There's no such thing as one size fits all or one methodology of treatment fits all. We have to consider the complexities of the individual we are serving. Consider reading milk flow rates from bottle nipples, What We Know and Why It Matters by Britt Pados. This research informs us that there are many differences in nipple flow rates, as well as the possibility of variability in flow rate within the same type of nipple. The name of a nipple, like just saying it's a slow flow nipple, is not always an accurate indicator of the flow rate. This research also informs us that nipples produced by Dr. Brown's provide the most consistent flow rate within the same type of nipple as compared to other nipples on the market. And why is this important? It's because consistency is key when learning a new task, especially in regards to a fragile infant that is requiring hospitalization in the NICU. This statement at the end that I just said is how I teach the bedside nurses, because I want to be objective as possible in that short time frame that we have to continue to speak after caring for the baby. Because again, these bedside nurses are navigating a lot of different infants just like we are. So again, consistency is key. And furthermore, this is my clinical opinion and how I personally operate within the NICU. I value the predictability and the consistency of the Dr. Brown's flow rates, but I also do utilize disposable nipples as well. So the NICU I serve has both reusable and disposable bottle systems. If you are not currently implementing reusable bottle systems within your NICU, consider creating an infection control policy following the manufacturer's guidelines for cleaning of these specific reusable bottle systems. Approximately 70% of infants within the NICU I serve receive Dr. Brown's bottles or nipples, and this is because of the predictable flow rate that these systems provide. I am personally an advocate for the Dr. Brown's Ultra Premium nipple, which provides a small bolus, allowing the infant to focus on learning to coordinate suck, swallow, breathe, rather than the volume consumed. But don't be fooled. I also recommend for infants to discharge home on the Ultra Premium nipple as well. When I first started in the NICU, I had staff tell me they can't go home on that. And I found that, and this is not objective data, this is just historically speaking, that I found that sometimes infants actually discharge faster when they're given this smaller bolus, because they're allowed to improve their respiratory health if they have respiratory complications, and learn to focus on suck, swallow, breathe coordination rather than inputting a faster bolus. So again, this is just my clinical findings. And as previously mentioned, approximately 30% of infants within the NICU I serve utilize disposable nipples. And generally speaking, infants that may be transitioning, meaning they're predicted to be in the NICU for a shorter amount of time, are generally provided a slow flow disposable nipple like the Similac or the Infamil brands. This may also be the case if the infant appears to be more robust. It maybe demonstrates an ability to manage the flow rate from these nipples. Again, these flow rates are a little bit more unpredictable, but you use them and toss them. And I also want to go back to the fact that all of these infants that are transitioning, they don't all get the disposable nipples. There are some instances where the reusable bottle systems are utilized. But it's important that in my clinical experience, it's important that there are options. Pillar 4 is importance of continuity of care. I believe it is our responsibility to aid our patients in connecting with the next provider. Do you know your local provider for therapy services? If not, try to connect with those in your community. Who follows up with the infants from the NICU? Do the families wait until they get to their pediatrician to determine if a referral is warranted, or is this referral established at discharge? In the NICU I helped formulate a system for referrals to our local early childhood intervention organization. This is run by the state of Texas. So whatever your state has. This referral is set up prior to discharge, and someone from the organization comes to the infant's home setting to begin the official enrollment process, generally within 1 week from discharge. This provides a great handoff of services from the NICU to home and allows the infant and family to be best supported. Remember, preventative care is best care. We do not want to wait and see if an impairment arises or worsens. Pillar 5, discussion of pediatric feeding disorder. We must be advocating about the significance of pediatric feeding disorder within our medical teams. This is a definition of pediatric feeding disorders by Feeding Matters. The website is provided on the slide. Pediatric feeding disorder is impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skill, and/or psychosocial dysfunction. Conservative evaluations estimate that PFD affects more than 1 in 37 children under the age of 5 in the United States each year. For these infants and children, every bite of food can be painful, scary, or impossible, potentially impeding nutrition, development, growth, and overall well-being. I picked this image on the side because I believe I want children to experience eating like this. I want eating to be fun for them. I want them to gain weight and lead fruitful lives. Confusion regarding use of ICD codes is common. Feeding skill domain practitioners may assume they are solely medical diagnostic codes to be assigned by a practitioner within the medical domain. However, ICD-10 codes also serve as treating diagnosis codes and may be used by licensed practitioners such as OTs and SLPs. Practitioners are encouraged to familiarize themselves with coding guidelines specific to their discipline. Again, this was taken from Feeding Matters, and the website is provided on the slide. PFD is applicable to children 0 to 17 years of age who fulfill the diagnostic criteria. Again, that's from Feeding Matters. I believe that decreasing the incidence of pediatric feeding disorder begins in the NICU. This is our responsibility if we work in the NICU to try to decrease this. But on the same account, increasing awareness about pediatric feeding disorder also begins in the NICU. This begins with discussions with our providers, discussion to the bedside nursing team, discussion to NICU leadership, as well as conversations with the families and the advocate for that child, and how maybe talk to them about how to offer suggestions or any causes for concerns with their providers outside of the NICU, because they really need to be educated on this topic. We all play a vital role within our unique NICU teams, and your NICU is unique. We're not all the same, and we all play an important role. I want you to know that your work matters. Your work is important. The babies and their families need us. Thank you for coming today. And now we will move into a Q&A.
Thanks, Casey. I just want to tell you how much we appreciate your honesty and your vulnerability and all that you're doing to really just help therapists and nurses all work together and just the collaboration. So thank you, thank you, thank you. And I know a lot of people on here follow you and really also appreciate all that information you provide too. So let me get a couple of questions here. One is related to standing orders. I know a lot of people don't have these, right? So if you don't have them yet, what would you see as some of the first steps as a way to get this to happen in your NICU?
So my first suggestion is to look at the NANT website, so the National Association of Neonatal Therapists website, to give yourself some more resources, and also look at the literature to provide your providers with. I know my physicians and nurse practitioners are very driven by the data and literature. One of the things that we know in my field in speech language pathology is that this research is growing now. But I would look at NANT first. And I mean, there's staffing suggestions provided by NANT as well. So you can look at that first. But it's also in the state of Texas, it's the law now to have therapy in the NICU if you're a level 3 or above specifically. I can't speak to others, but just look up your state regulations as well.
Great. What about, so there's some questions about the diagnosis PFD. Should we be using the diagnosis in the NICU? And I'm going to combine that with another one that is, are providers aware about this, that it's an actual diagnosis now?
So that goes back to my slide about, I believe it's our responsibility to educate our providers on it, because I don't think a lot of providers know about it. I did a presentation, I believe September 2021, and educated it about the upcoming diagnosis code. I think it started in October. And I remember a lot of people were live in the room with me, and a lot of people were online listening. And I remember looking at the faces of the providers. I mean, they didn't know. So I would suggest for you to maybe give a presentation to your providers. If not, give a handout and send it through email. In regards to using the diagnostic code in the NICU, I specifically describe it in my note like they're at risk for pediatric feeding disorder. And then I think that's something I also could use more education on, but that's something you can reach out to Feeding Matters about, because they're really on the forefront of this, and to get some more insight, because I feel like they can help guide you in a way that maybe I cannot.
Great suggestions. Thank you. Let's see, how long has your journey taken to actually be on the team in the NICU? Long time.
Yeah, I feel like I'm really open and transparent about my journey. At least I hope you feel that way. I mean, it's been years. I mean, it took so long to get a job in the NICU. I think if you are in the therapy world, you know, it's really hard and rare to get. So I had to put in the work first to get there. And then when I got there, I was like, oh my gosh, I had no idea what I was, you know, the work ahead of me. But that's one reason I'm such an advocate at this level, and getting to give webinars like this is to help you guys, because I was in your shoes. But I think to get where I am now, probably, you know, 4 years, 3.5, 4 years. And I'm not saying that's how long it's going to take for you. Your situation is unique, your NICU is unique. And maybe that person before you, I did a lot of headway. And I also know the person before me did as well. So I want to give credit to that person. It's just your NICU is unique, and there's always new opportunities for improvement and growth.
Exactly. Thank you. Back to the ICD code. Is there a CPT code that correlates with that new ICD code? And how do you generally bill for your services in the NICU? That question comes up a lot. So
yeah, so that's like a really complex question for me to answer on this recorded webinar. So again, I would reach out to Feeding Matters, but I do, I bill separately for, and this is based on your hospital system, I believe. So look into your hospital system and your leadership, but I bill a separate code for developmental care, and then a separate code for swallowing and feeding, because they are 2 different domains. And so in my hospital setting, I have been guided by my leadership to use, I don't know the actual number, but it's a speech code for communication and development in terms of 2-person cares, because when you take a step back, everything we're doing is immersed within the baby. You're helping the baby thrive in his or her environment. So again, I think you're going to need to consult your hospital leadership to get more guidance, but I do use 2 separate codes for the 2 different domains per se. You have to make it more objective and black and white.
thank you. And I agree, there should be someone in every facility who, whether it's the manager of rehab or who's really, really knowledgeable about those codes as well. Okay, we got a lot more questions. I want people to know, if we don't get to your question, all the questions will eventually be answered on the website, along with the handouts and the recording. What is the time frame your unit uses for protected breastfeeding window before the bottle is introduced? And how have you been successful in helping promote that precious window and not forcing bottles too quickly?
So for me, I became a certified lactation counselor that helped guide me to have more understanding with the complexities of breastfeeding, rather than sticking just to the domain of the bottle feeding. So I'd encourage you to do that. And then we do have a protected window, and I call dry breastfeeding or nuzzling breastfeeding. And I encourage you to do so as well, because it is exploring the breast. So I'll be quick, but one thing I try to do, especially when these babies might be on 4 liters or higher levels of respiratory support, is say that we're breastfeeding, maybe when we're dry breastfeeding. So it helps wean the flow. So it's not like 3 days or 4 days or 5 days. It's really transparent and changes every day based on the baby and the communication with the parent, and say, okay, do you feel ready to bottle feed? Or if they're not ready, give them an additional day to work on breastfeeding, because it is family-centered care. But I don't have a black and white answer for a length of time, because I don't work in a manner that is very rigid like that. And I mean that respectfully. It just changes every day.
Right. And might be infant independent too, right?
Exactly.
And family independent,
Yes.
family independent,
Yes.
right? Oh, great information. I'm going to save the rest of the questions since we're running out of time, and I know people have to get back to their patients. But we just want to thank you so much for being here. I know everyone on here says thank you, and we'll get those questions to all of you.